So the hamstrings are a difficult and very intimidating ultrasound examination, but clinically these are pretty straightforward. There's essentially two ways in which you'll tear your hamstring. One, you have an overstretched mechanism of injury. This is basically where patients will do the splits and they're not used to normally doing the splits, such as what happens to Latrell Mitchell's left hamstring here. If we have this sort of presentation, I'm thinking a free tendon tear. The other way you'll tear your hamstring is when you are running at pace. The hamstring will act to slow down that lower leg, and as it extends, you are prone or susceptible to a musculotendinous junction tear. Either way, they're clinically pretty straightforward. So if your patient has a plausible clinical history of a hamstring tear, your worksheet should never read NAD. If it does, it's not because there's no abnormality, it's because we've missed it. You need a methodical, a systematic, and pragmatic approach to these ultrasound examinations. If we scan these like we scan a breast or like we mow the lawn, we've got no hope. We might get lucky and see the hematoma, but we'll have no hope in being able to identify what part of that muscle tendon unit has been affected. And that is our primary objective. And before we start, there's three things that I want you to forget. The first is to forget this notion that we have to grade a hamstring tear. There's this notion that we have to apply a BEMIC grading or an Otto-Chan grading to our ultrasounds of hamstring tears. We don't need to do that. If we strip things right back, our primary goal is to identify what part of the muscle tendon unit has been affected and to describe that accordingly. If we do that, either the radiologist or the referring clinician can use whichever system they so choose to grade these tears, but it need not be any more esoteric than that. So the key is to understand the muscle tendon unit, and that forms the heart of my approach to hamstring ultrasound. And what we need to understand is that the muscle tendon unit differs from these sorts of illustrations. Now you see these illustrations everywhere you turn. They depict the tendon as a discrete and distinct entity that connects the muscle to the bone, but in reality it's far more intricate yet far more elegant. Tendons are non-linear projections that pierce the center, the periphery, and sometimes both parts of the muscle simultaneously. And if we understand this, if we understand how something is constructed, we understand how something fails. And the last thing to forget is Frank Natter. I always get very nervous when I see someone go to Frank Natter before they have to perform an MSK ultrasound examination. Now, I've got nothing against Frank Natter. These are spectacular illustrations, but they're also very overwhelming because of the amount of information that's present. If we're looking at this before we go in to scan a hamstring, it's very easy to become overwhelmed. It's very easy for our game plan and our process of thinking to become clouded because we've become so overwhelmed with the amount of information that's present here. The other thing is that Frank Natter doesn't show the musculotendinous junction of the hamstrings. If we need some illustrations to help guide us, then let it be this from Inigo Iriarte. He has probably one of the best MSK ultrasound textbooks there is, Ultrasound of the Musculoskeletal System. And what makes this image really nice is it actually shows and depicts those muscle tendon units. So my starting point for any hamstring ultrasound is semimembranosus. In particular, the free tendon of semimembranosus. I start here at the so-called pseudosciatic nerve because it allows me to get my eye in. That's my first goal, is to identify the free tendon and this pseudosciatic nerve. And it also allows me to assess what is the less complex muscle of the hamstring. So once I see the free tendon, I work distally, and my eyes are on the white bit, the muscle tendon junction of semimembranosus. I'll scan all the way through until I cannot see that tendon anymore. And if I scan in live, I can see that free tendon, and as we come down, we can see the muscle fibers being thrown off medially, and again my eyes are on the white bit. I'm looking at the musculotendinous junction of semimembranosus. I'll scan through to that area and then work my way back up until I get to the free tendon of semimembranosus. Once I get to this point, I'll scan proximally all the way up to the origin. And the origin of semimembranosus will be lateral and deep to the conjoint tendon, just adjacent the sciatic nerve. Distally, we've all scanned the insertion of semimembranosus. If we've scanned a Baker's cyst, we've scanned semimembranosus, and not too much will go wrong here. So this was a tight head prop, first grade rugby player who went to pilfer a ball at a ruck. He was cleaned out. So he has more of an overstretched mechanism of injury. So again, I'm thinking free tendon tear, and he does indeed have a partial thickness tear of the free tendon of semimembranosus with a concurrent tear of the proximal MTJ. This was a gentleman who had an ice skating injury. We can see quite marked edema at that proximal musculotendinous junction. And at the free tendon, we can see this wavy or detensioned appearance to the free tendon. And that's really important to note. That will suggest more a high-grade tear or high-grade injury. So as we scan down, we can see this anisotropic effect because of that detensioned or wavy free tendon. And we can see extensive edema throughout that proximal musculotendinous junction of semimembranosus. This was a 16-year-old soccer athlete. In transverse, we can see edema through that proximal musculotendinous junction, and that extends essentially the entire length of that proximal MTJ. As we scan down from the origin, we can pick up the free tendon of semimembranosus, which is intact and normal, but the abnormality occurs here at that proximal musculotendinous junction of semimembranosus. This was a CrossFit athlete who had a history of a hamstring tear 3 months prior, had been getting back to CrossFit and doing some short runs, but still had a bit of discomfort. And you can see a small acute on chronic tear of the proximal MTJ. So without a systematic and methodical approach, these smaller, more subtle tears could easily be missed. But if you know how to look and where to look, these become quite a satisfying exam to perform. That essentially takes care of semimembranosus. So once I get semimembranosus out of the way, I then look at the distal biceps femoris, the T-junction of the biceps femoris. So distally, the muscular component is that of the short head, and we can see the tendon over the top. As we move further up, we can see that T-junction. And as we come a little bit further up, again, we can see long head and short head. Now, short head doesn't go all the way to the ischial tuberosity. It will insert onto the linea aspera of the femur. So as we scan up, we can see short head and long head. Short head will insert onto the linea aspera of the femur at this point, and then I'll scan back down. But again, as I'm making this assessment, my eyes are on the T-junction. I'm looking at that tendon and that muscle tendon unit of the distal biceps femoris. Now distally, the biceps femoris will insert predominantly on the fibular head, although it can insert some fibers onto the tibia as well, not dissimilar to how a peroneus longus will insert. This was a 16-year-old AFL athlete who was 6 weeks post-injury, and clinically he was performing well. They were looking at playing him the following week, but you can still see a small but significant tear of that T-junction. So as we scan down from proximal to distal, my eyes are on the T, my eyes are on the white bit, and we can see discontinuity through that T-junction. So although it's a small tear, it's still quite a significant tear. And these injuries are renowned for having a high recurrent rate. This was a snowboarding injury who presented several weeks after his injury. And as we scan up, we can basically see, as we scan down, we can see significant edema and abnormality through that T-junction. It's very difficult to identify any normal tendon until we get to that knee joint level where we can pick up the insertion of the distal biceps femoris. As we start to scan back up, we can see that discontinuity and quite a high grade tear of that distal T-junction. From there, I'll move proximally and then look at the proximal aspect of the biceps femoris. So I start, it's quite a way down the hamstring, pick up the white bit again, and as I move forward, my eyes are on the white bit. We can start to see a contribution of fibers from semitendinosus, hence the conjoint tendon. And the conjoint tendon will insert or have its origin more medially and superficial than that of semimembranosus. So scanning live, again, as we scan up, I'm looking at that white bit, I'm looking at that proximal MTJ of the long head of biceps femoris. At this point, it's important to use a few different angles with your probe. So with this image, you can see a pretty high grade tear through the proximal aspect of the right long head of biceps femoris. Sometimes I will use this split screen as well when I'm scanning hamstrings. I can identify what is normal, and that provides a really good baseline for when you have some more subtle or some injuries in which you're not quite sure. So as we scan down, again, if we rock our probe from side to side, just to try and get the best angle, we can pick up any defect through that tendon. This was an athlete who came in query tethered sciatic nerve. There was no tethering of the sciatic nerve, but we've got a very subtle abnormality at the distal end of the proximal long head of biceps femoris, the MTJ. And again, another elite athlete who've got some subtle discontinuity, some subtle blush at the distal end of the proximal MTJ of the long head of biceps femoris. So as we scan down, again, I'm looking at the white bit and we can just see just there a small blush and bleed at the distal end of the proximal MTJ. From that point, I'm going to move on to semitendinosus. I find it easier to pick up distally. It's the little cherry on top. So this is semitendinosus. The muscle underneath is semimembranosus. And as we move proximally, we can start to see some muscle fibers. And then we can move right up where we've got this intramuscular inscription or raphe, which I use basically as a landmark to help me identify semitendinosus. Now distally, semitendinosus will form the most inferior aspect of the pes and serine tendon. And again, not too much will go wrong distally at semitendinosus. The only time that you see abnormality with semitendinosus is post-ACL reconstruction. The surgeons will often use semitendinosus as a graft for the ACL replacement. And then typically what happens is you get this sort of appearance where you've got atrophic echogenic semitendinosus and you won't be able to see the tendon from about this point here. It's gone. It is no more. This was an athlete 2 months post ACL, just doing some minor rehab, and you can see basically a complete tear of that semitendinosus. So sometimes the surgeons will grab too much semitendinosus. That's not their focus. Their focus is on repairing the knee. So what often happens is the semitendinosus and the hamstring will fail in the 12 months post ACL reconstruction. Sometimes we get this sort of appearance. So this was a 60-year-old lady who slipped on some wet tiles. So basically she did the splits when she doesn't normally do the splits. So again, I'm thinking free tear. So these can be really difficult, these injuries. You'll note with this scan that we've got quite a lot of echogenic fat and we've got some fatty replaced glute max. So when you have that, then these scans are going to be pretty difficult. What you can do is you can work either with or against that glute max fold to try and optimize your window. In this case, when I'm quite unsure what I'm looking at, I will scan the other hamstring because that will provide a baseline for what is normal in this case, and that will give me confidence to say there's been a complete tear of both semimembranosus and the conjoint tendon. If I've got complete tear and I cannot recognize any normal anatomy, I'll try and give the surgeons an idea as to how far that tendon has retracted from the ischial tuberosity. We had some good questions at the workshop last week. One was regarding tendinopathy and being able to identify hamstring origin tendinopathy. So this will be like any other tendon. You'll get a hypoechoic, a thickened tendon. Often you see a little bit of edema around there as well. Sometimes that origin can be a little difficult to assess on ultrasound. So typically the hamstring origin tendinopathy will occur in runners, and often you'll see a bit of irregularity of the ischial tuberosity as well. So sometimes being able to identify that cortical irregularity of that ischial tuberosity will help you to indicate that there's a bit of hamstring origin tendinosis. Not too difficult in this case. It's quite severe tendinopathy, tendinosis with some high-grade tears through both the semimembranosus and conjoint tendon. And there was a few other questions too. One really good question was regarding measurements of tears. So you'll notice with the majority of my scanning, I was scanning in short axis or transverse. So that's not by coincidence. Essentially all of my scanning for whatever MSK examination it is in short axis. Once I see a tear though, I will try and measure the length and the width of that tear and give the radiologist or the surgeon an idea as to the size of the tear. But I think the size of the tear is not quite as important as being able to identify or accurately describe the location of the tear. So that small T-junction tear, for example, that's quite a high-grade tear. Although the size is small, this location is significant. So don't get too worried about measuring the size of the tear. Yeah, it's important just to give the radiologist and the surgeon an idea of how big the tear is. But I think our priority should be accurately describing the location of that tear more so. I think that's about it, guys. Feel free to reach out if you have any questions. I do put some videos like this one onto Instagram, a little bit onto YouTube as well. So if you enjoy the videos or if that will help, then feel free to jump on and have a look. Sonography_secrets is the handle for that. And these are the sort of videos that I put out there. So basically showcase normal anatomy and how-to tips or tricks, and sometimes I'll put some case studies on there as well. And I think a lot of people have told me they've found it beneficial as well. So feel free to jump on, get in touch, and happy scanning.